I'm Karine Jocelyn from the Haitian Women's Collective, and we really appreciate your joining us this morning. Thank you for registering. Thank you for taking time out of your busy schedule to join us about a really important topic. First, I want to say the Haitian Women's Collective is a collective of Haitian women-led local organizations based in Haiti. And they do diverse work. And so we're always here to amplify their voices and to celebrate and recognize the work that they do. As I mentioned, the organizations do things from education, safe housing, addressing gender-based violence, healthcare, and so forth. And today, our topic is around maternal health. These are one of the topics that evolved in our conversations with many of our partners and allies to the collective when we launched our strategic plan in July of 2023. Actually, our plan is finished. And in addition to sexual and reproductive health and rights, the issue around gender-based violence and prevention of really rose to the top. So we wanted to certainly address this during Women's Month. And obviously, maternal health is an issue globally. One of the other areas, or some of the other areas that came up as priorities during the strategic planning process was also girls' leadership development and girls' empowerment, as well as economic development, and looking at it also across kind of a climate justice issue. And we have been, as a collective, during our various sessions or meetings, really talking about mental health and burnout and seeing how we can address issues of healing. I don't take lightly that people in Haiti are going through an incredibly challenging and crisis time. So I do want to uplift that and thank, obviously, our speakers today and Dr. Vorbe, who is in Haiti and doing this work locally. So I just, of course, wanted to say that and thank both of our speakers today, who, when I sent them an email, they agreed to be here, even though they are both very busy. So thank you again for joining us, and we will move forward with the conversation. Both speakers will do a presentation. We will do question and answers at the end. Please be advised, we do have interpreters. We do, at the collective, we've really been taking a closer look at language equity and want to be able to provide interpreters when we have public webinars. So there is a process if you do need interpretation to choose the globe at the bottom. I don't know if one of the interpreters would like to give directions in Creole or in French. I could do it, but I just want to be sure that I'm saying the right thing. Surely, or perhaps we have it written in the chat. I just want to be sure. OK. Bon, m'a dit la créole. Si gen moun kap participer et nous pas parler anglais, ou bien la plus facile pour nous tendre li en créole, m'kwe que peut-être en français tout, et gon ti globe qui pa en bas écran, n'a cliqué li, et puis n'a choisi qui langue nous vle et tande nous vle participer. OK? Merci. And so we will continue. I don't know if we made a decision of who would go first, but I think I will start with whoever wants. Does anybody want to raise their hand and tell me who is okay with going first? Florence or Christina, either of you? Florence. All right, very good. Dr. Florence Jean-Louis Vorbe is the Executive Director of Pro Famille. Wonderful, great work, an amazing leader. We've shared her bio before. And so in essence of time, I will pass it on to Florence, who will do her presentation now. Thank you again for joining us. Florence?
Yes, merci Karine. Puisqu'on a des interprètes, je vais parler en français. But I understand and I can speak English when you have questions. Ce que je voulais dire, c'est que ProFamille, c'est une institution d'abord qui travaille sur la santé sexuelle et reproductive. Notre principal mandat, c'est d'offrir des services, mais bien entendu, pour pouvoir donner l'accès aux services, on a aussi besoin d'informations, de plaidoyer et de défense des droits sexuels et reproductifs. Donc, c'est en gros ce que fait la ProFamille en Haïti. Par rapport à la crise actuelle, nous avons dû fermer une clinique déjà à la Croix-des-Bouquets et nous avons 2 cliniques avec déjà des plans d'évacuation prêts à être mis en place à Turgeau et à Delma. C'est la situation actuelle. OK, donc je vais partager mon écran, je pense. Est-ce que vous pouvez confirmer que vous voyez?
Oui, ça va, Florence, merci.
OK, parfait. Donc là, je vais parler de la santé maternelle des femmes haïtiennes, de ce côté sous bord de l'eau ça. Et puis, Christina a parlé sous santé femme haïtienne, l'autre bord de l'eau. Par rapport à la définition, je voulais vraiment commencer par ça parce que c'est important quand on en parle. C'est la définition de l'OMS, bien entendu. Donc, la santé maternelle se rapporte à la santé des femmes pendant la grossesse, l'accouchement et la période postnatale. Donc, depuis ma femme enceinte jusqu'à 40 jours après que les filles ont accouché. Chacune de ces étapes devrait être une expérience positive permettant aux femmes et à leurs bébés d'atteindre leur plein potentiel de santé et de bien-être. Ça devrait vraiment être une expérience positive pour les femmes, mais on va voir que malheureusement, souvent, ce n'est pas le cas. En Haïti, on a une grosse charge de mortalité maternelle qui est donc la mortalité qui a lieu pendant la grossesse et dans la période postnatale, dans la même période dans laquelle on parle de la santé maternelle. Mais si on se penche dessus, la plupart des décès maternels sont évitables. C'est pas un destin, c'est pas une fatalité, c'est évitable grâce à une prise en charge rapide par un professionnel de la santé qualifié, exerçant dans un environnement favorable. C'est pour ça que souvent, quand on parle des décès maternels, on parle aussi globalement des inégalités sociales. On voit des pays qui ont le moins de ressources, le moins de possibilités, le moins de services, que les femmes meurent au cours de la grossesse, de l'accouchement et dans la période postnatale. Chaque grossesse et chaque naissance sont uniques. Il est donc fondamental de s'attaquer aux inégalités qui nuisent à la santé, en particulier à la santé sexuelle et reproductive, aux droits connexes et aux genres, si l'on entend garantir à toutes les femmes un accès à des soins de maternité respectueux et de qualité. Donc, il y a plusieurs déterminants sociaux qui sont liés directement à la santé maternelle et donc aussi à la mortalité maternelle. OK, là, je vous montre un tableau comparatif de la mortalité maternelle en Haïti. Vous voyez là, 529 femmes meurent pour 100 000 naissances vivantes. C'est le chiffre le plus élevé de l'hémisphère et un des 10 chiffres les plus élevés au monde de mortalité maternelle. Sur 61 femmes qui sont enceintes, il y en a une qui a un risque de mourir. Regardez la comparaison avec les autres pays. Premièrement, globalement, Amérique latine et Caraïbes, ça veut dire toute l'Amérique du Sud, l'Amérique centrale et les Caraïbes, le chiffre de mortalité maternelle auquel nous contribuons, nous, Haïtiennes, avec nos 529, est de 74. À Cuba, c'est 36 femmes seulement qui meurent pour 100 000 naissances vivantes. En République dominicaine, là, à côté de nous, 5 fois moins de femmes meurent. 95 pour 100 000 naissances vivantes. En Jamaïque, 80 pour 100 000 naissances vivantes. Donc, vous voyez le risque, là, comment ça change. En Amérique latine et en Caraïbes, le risque pour nous est 100 fois plus élevé. Les causes principales de mortalité maternelle, qu'est-ce qu'elles sont? Tout le monde se pose, c'est les mêmes causes que dans tous les pays du monde, sauf que nous, on ne les gère pas. Les hémorragies sévères qui peuvent être gérées avec des soins obstétricaux d'urgence et la disponibilité de sang. OK? Première cause. Deuxième cause, l'hypertension pendant la grossesse qui peut être gérée en partie avec un bon suivi prénatal. On va voir que nous, en Haïti, on a le suivi prénatal, mais peut-être qu'on ne fait pas tous les gestes et tous les contrôles qu'on doit faire pendant ce suivi prénatal. Autre cause très, très, très importante, troisième cause, l'avortement non sécurisé. Ça veut dire toutes les femmes qui ont une grossesse non désirée, qui désirent faire un avortement, qui ne trouvent pas d'endroit sûr pour faire l'avortement et réalisent ces avortements, donc ces interruptions volontaires de grossesse, de façon clandestine avec des personnes qui ne sont pas formées dans des milieux qui ne sont pas sécurisés. Grosse cause de mortalité en Haïti où l'avortement est criminalisé à 100%. L'obstruction lors de l'accouchement. OK? L'obstruction lors de l'accouchement, ça veut dire que la femme a un très petit bassin ou l'enfant a une très grosse tête. C'est assez rare, les dystocies ou bien des présentations de l'enfant qui peuvent être un obstacle pour sa naissance de façon physiologique normale. Et finalement, l'autre cause importante, c'est les infections. Les infections suite à un avortement, par exemple, les infections parce que l'accouchement a été mal géré, mais ces infections-là, on peut les prévenir avec une bonne consultation postnatale, si l'accouchement est fait avec un personnel formé ou si l'avortement est sécurisé. Donc, la situation de tous ces déterminants dont je vous parlais tout à l'heure, les soins obstétricaux d'urgence. Donc, la première cause, on a vu, c'est les hémorragies sévères. Pour ça, on a besoin de soins obstétricaux d'urgence et de sang. OK? Les soins obstétricaux d'urgence sont offerts seulement dans 11% des institutions. Et on va voir plus en avant que les de ces institutions qui offrent des soins obstétricaux d'urgence. Haïti a un besoin urgent d'accroître sa production de sang sécurisé avec une demande annuelle, vous m'écoutez, entre 60 000 et 80 000 pochettes contre une production annuelle actuelle de seulement 20 000 pochettes. On a besoin de 4 fois plus de sang que ce qu'on produit. Et je ne vous raconte pas les problèmes actuels qu'on ne peut même pas importer, qu'on ne peut même pas faire venir parce qu'on est en prison, enfermé de tous côtés. On ne peut pas sortir par voie aérienne. On ne peut pas sortir du côté de la frontière dominicaine qui est fermée et on ne peut pas sortir par la mer. Donc, on doit se contenter de ces 20 000 pochettes quand elles sont disponibles pour sauver la vie de quelques-unes. 67% des femmes enceintes, donc je disais tout à l'heure, ça c'est la bonne nouvelle, assistent quand même aux visites prénatales. Oui, elles sont inquiètes pour leurs enfants, elles veulent savoir si leur grossesse est une grossesse à risque et c'est peut-être ça qui va les décider d'aller accoucher dans un centre. Si on leur dit que leur grossesse est à risque, elles ont un problème. OK? Donc, elles vont aller assister aux consultations prénatales. Cependant, 61% des femmes vont accoucher à domicile. Il y a un minimum de grossesses qui sont à risque. Donc, une fois qu'elles savent qu'elles ne sont pas à risque, elles préfèrent accoucher à domicile et on va voir pourquoi. OK? Et pour les soins postnatals, ça veut dire pour prévenir les infections, par exemple, très peu de femmes assistent à la consultation postnatale. D'un côté, parce que alors qu'elles vont au centre de santé pour se faire vacciner, pour faire vacciner leur nouveau-né, elles ne se présentent pas à la consultation postnatale alors qu'elles sont dans le lieu de la consultation. Maintenant, pour l'avortement, comme je disais tout à l'heure, la loi en Haïti interdit le recours à l'avortement volontaire dans tous les cas. Dans tous les cas, ça veut dire inceste, viol, mise en danger de la vie de la femme, mise en danger de la vie. Il y a en aucun cas, la loi haïtienne permet le recours à l'avortement volontaire. Dernièrement, on a eu par décret un code pénal qui est sorti, mais qui n'a pas encore été appliqué. Et dans ce code pénal, il permet que dans les 10, je ne me souviens plus si c'est dans les 10 ou 12 semaines, OK, qu'une femme peut avoir recours à l'avortement en cas d'inceste, en cas de viol, ou si le produit met en danger la vie de la mère. OK? Mais ce n'est pas encore en application. Et même que ça sera en application, il y aura beaucoup de questions parce qu'on l'a vu dans d'autres pays. Quand on a des lois aussi restrictives, pour que la justice permette à la femme d'accoucher, de faire un avortement dans le temps qui est imparti, ça prend beaucoup plus de temps dans les 12 semaines et quand finalement la justice statue, la femme n'a plus l'accès à l'avortement. Donc, les lois restrictives comme ça, point d'interrogation, mais quand même, c'est un petit plus par rapport à ce qu'on a maintenant, mais ce n'est pas encore en application, comme je vous disais. Or, on sait que 57% des grossesses ne sont pas désirées. Je ne parle pas seulement des adolescentes, je parle de femmes mariées qui ont déjà assez d'enfants et alors qu'on n'a pas accès au planning familial en Haïti. Seulement 17% des institutions offrent une gamme assez variée de planning familial. OK? Donc, grossesse non désirée de femmes mariées, de jeunes ados, de personnes dont la méthode de PF n'a pas marché, etc., 57%. Et on estime que la moitié vont aboutir à un avortement provoqué. Que ce soit dans des bonnes conditions ou dans des mauvaises conditions. Et c'est là aussi qu'on voit comment les inégalités sociales sont graves. Parce que moi, Florence Vorbe, je suis médecin, j'ai quand même un visa pour aller dans d'autres pays peut-être. Donc, si ça m'arrive, je peux voyager et aller avoir recours à un avortement sécurisé, légal, quelque part, qui ne met pas du tout en danger ma vie, où j'ai aucun risque pour ma vie. OK? Mais je suis une privilégiée. 80% des femmes haïtiennes ne jouissent pas de ce privilège et doivent aller chercher, soit avoir beaucoup d'argent pour aller voir un médecin privé qui va les exploiter, les extorquer pour faire quand même un bon avortement, ou bien aller voir un charlatan qu'elles vont peut-être payer moins cher, OK? et qui va mettre en danger leur vie. Donc, c'est ça la situation de ces femmes-là. Et il faut bien dire que 75% des avortements qui sont provoqués dans un contexte légal restrictif sont des avortements non sécurisés qui mettent en danger la santé et la vie des femmes. Donc, vraiment, quand on parle de santé maternelle, il faut vraiment parler de légalisation de l'avortement pour améliorer nos services. Maintenant, je voulais faire un point sur les accouchements à domicile parce qu'on dit, mais pourquoi les femmes, si elles savent déjà, elles vont à la consultation prénatale, elles savent déjà qu'on leur conseille d'accoucher dans une institution, pourquoi elles n'y vont pas? Première barrière, l'accès financier. Donc, dans les hôpitaux publics, les soins sont supposés être gratuits ou pour un coût minimum. Cependant, nous, on a vu et on a fait l'expérience à la Profamille avec des femmes qu'on accompagne parce qu'on n'a pas de maternité. Donc, on les accompagne dans une institution pour accoucher. En moyenne, elles doivent dépenser 40 000 gourdes parce que l'hôpital n'a pas de gants, l'hôpital n'a pas ce médicament, l'hôpital a ci, l'hôpital a ça. Donc, finalement, de leur poche, pour accoucher, elles doivent dépenser 40 000 gourdes. Et je vous rappelle que 40 000 gourdes, le revenu mensuel d'une Haïtienne, en moyenne, et je dis bien en moyenne, est de 18 000 gourdes. OK? Et quand je dis en moyenne, c'est vraiment parce qu'il y a des gens qui ont des revenus très élevés et d'autres qui ont des revenus très, 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 très bas. Donc, ce n'est pas la médiane, c'est la moyenne. L'autre obstacle, c'est l'accès géographique. On en a parlé, je vous en ai parlé tout à l'heure. L'accès aux institutions de santé est limité. 42% des ménages haïtiens doivent parcourir plus de 10 kilomètres pour atteindre la structure de santé la plus proche. OK? Et beaucoup doivent parcourir ces 10 kilomètres à pied ou à dos de bête ou à moto. Donc, ce ne sont pas des parcours. 10 kilomètres peut paraître pas beaucoup, mais ce n'est pas des parcours faciles dans la majorité des cas. Et l'accès culturel, qu'on oublie souvent, mais il faut dire que pour les femmes haïtiennes, l'enfantement constitue premièrement un événement familial. Ça veut dire qu'elles sont en travail, mais elles sont chez elles, leur maman caresse leurs cheveux, leur grand-mère leur apporte du thé, leur mari les soutiennent, même leurs enfants sont là aussi. Donc, culturellement, c'est un moment qui se vit en famille. Or, dans les institutions, elles ont de la chance qu'on laisse passer une personne avec elles dans la salle de travail. Donc, ça veut dire qu'elles doivent accepter de passer 8, 10, 12, des fois même 24 heures de temps, toutes seules en travail, sans un petit geste de tendresse, sans des mots d'encouragement de la part de leur famille. Donc, ça, c'est une des raisons qui font qu'elles préfèrent accoucher à domicile. Une autre raison, c'est que quand elles sont chez elles, elles sont libres de leur mouvement. OK? Elles marchent, ce qui facilite bien entendu le travail. Elles peuvent marcher, se coucher sur le côté, sur le dos, s'asseoir, se balancer. Beaucoup aiment se balancer, cadencer à l'haïtienne. Ça les aide beaucoup. Elles peuvent chanter, elles peuvent faire tout ce qu'elles veulent, même manger et boire, et même au moment de l'accouchement, elles peuvent accoucher accroupies, à quatre pattes, qui sont des positions beaucoup plus faciles qu'accoucher sur le dos avec les quatre fers en l'air. Et tandis qu'à l'hôpital, elles sont connectées, elles sont intervenues, on les empêche de manger, de boire, etc. Et leurs mouvements sont très limités. Donc, ça, c'est une deuxième cause. Et la troisième cause, c'est la peur. Une peur parce qu'il y a toutes sortes d'histoires qui circulent sur des gens qui accouchent dans les institutions. Donc, elles ont peur du gant. Le gant, c'est le toucher vaginal qui, on le sait, n'est pas toujours nécessaire chaque heure de temps d'aller checker. Elles n'aiment pas ça, elles ont peur de ça et des fois, c'est forcé. Elles ont peur de l'épisiotomie qui souvent se fait systématiquement alors qu'elles peuvent accoucher chez elles sans déchirure, sans rien, sans avoir besoin de l'épisio. Donc, ils ont peur gants, ils ont peur ciseaux. Elles ont peur de la césarienne, bien entendu. Premièrement, parce que ça leur coûte plus cher. Deuxièmement, parce que c'est leur chair qui est coupée. Et troisièmement, elles croient fortement qu'on leur fait que accoucher en institution augmente leur risque d'avoir une césarienne. Et tout ça pour elles, c'est de la violence. Elles se sentent victimes, elles se sentent sans pouvoir, à la merci des prestataires de santé qui très souvent ne les traitent pas bien. Donc, les propositions pour tout ça, par rapport à toute cette situation et par rapport à qu'est-ce qu'on pourrait faire pour que la santé maternelle, pour améliorer la santé maternelle des femmes haïtiennes en Haïti. Premièrement, développer un modèle de maison de naissance où les habitudes culturelles qui ne sont pas nocives sont respectées et où les habitudes médicales contraires à la physiologie de l'accouchement sont abandonnées. Ça veut dire que, imaginons un espace géré par des prestataires formés où une femme, si elle veut, peut accoucher à 4 pattes, par exemple. Une chose. L'autre chose, implanter des espaces d'attente pour grossesse à risque autour des institutions obstétriques. Qu'est-ce que c'est? Il y a les femmes qui ont des grossesses à risque, mais à cause de l'accès géographique, disons que même si elles ne peuvent pas arriver à temps, elles pourraient avoir un espace comme une espèce de pension quand elles arrivent tout près de leur terme, autour de l'hôpital où elles pourraient être logées pour attendre le moment de leur accouchement et à ce moment, améliorer leur chance d'être prises en charge si elles ont un problème. Troisième proposition, développer les compétences des femmes enceintes pour qu'elles comprennent le processus de l'enfantement et connaissent leurs droits en tant que demandeuses de services. Parce que pour l'instant, elles subissent, mais si elles connaissaient leurs droits, si elles connaissaient le processus, elles pourraient exiger des prestataires, par exemple, que les prestataires leur donnent de meilleurs soins, des soins de meilleure qualité, des soins plus attentionnés, elles pourraient savoir qu'elles peuvent dire non au toucher vaginal, par exemple, qu'il faut leur consentement pour qu'on leur fasse un toucher vaginal. Quatrième proposition, travailler avec les matrones traditionnelles pour leur redonner confiance et pour qu'elles deviennent un maillon de plus dans la chaîne de sécurité des femmes enceintes, pour travailler avec les institutions, tout en leur redonnant de confiance de façon à ce que vraiment on puisse travailler ensemble pour la sécurité des femmes enceintes. Travailler avec les prestataires de santé pour qu'ils comprennent leur rôle dans le processus de naissance et pour qu'ils respectent le pouvoir et la dignité des femmes dans le processus. Chose très importante, bien entendu. Continuer le travail de plaidoyer pour la décriminalisation et la dépénalisation de l'interruption volontaire de grossesse. Continuer le travail pour la socialisation de la discussion sur l'interruption volontaire de grossesse. Alors ça, c'est à deux niveaux. Un niveau qui est surtout au niveau des lois, le plaidoyer pour la décriminalisation, mais aussi au niveau de la société, vraiment travailler, retirer les tabous, les mythes, permettre que tout le monde puisse en parler. Parce que, qu'on le veuille ou non, même si on n'en parle pas, la majorité des femmes ont dû faire face à cette décision à un moment et les hommes aussi y ont participé. Donc, pourquoi ne pas en parler sans tabou, sans mystification? Autre proposition, initier le travail de sensibilisation sur les violences obstétricales et les mobilisations contre. Les violences obstétricales sont une violence basée sur le genre qui existe et dont pour l'instant, on n'est pas encore conscient. Nous, en Haïti et beaucoup de sociétés dans le monde. Donc, il faut vraiment travailler il faut vraiment qu'on travaille sur ça, que ce soit du côté des femmes qui en sont victimes, que ce soit du côté des prestataires qui sont, si vous voulez, perpétrateurs de ces violences, des fois, sans se rendre compte que ce sont des violences. Et puis, continuer à exiger l'accès à des soins obstétricaux d'urgence fonctionnels et prêts à livrer toute la gamme de services. Parce que même quand on parle de ces 11% d'accès à des soins obstétricaux, des fois, il n'y a pas de sang, des fois, il n'y a pas de personnel 24/24. Donc, il faut vraiment augmenter, mettre plus haut le niveau de ces services-là. Donc, je propose de changer le narratif, de dire que ce sont les femmes qui enfantent et pas les prestataires qui les accouchent. Parce qu'une femme, à son terme, va accoucher de toutes les façons. Les prestataires sont là pour faciliter l'accouchement. Donc, les femmes, elles doivent pouvoir enfanter dans la dignité et dans leur pouvoir de savoir que leur corps est capable et qu'elles savent aussi ce qu'elles doivent faire pour accoucher. Donc, on doit leur restituer définitivement le pouvoir autour de l'accouchement au lieu de les traiter comme des objets passifs sur lesquels on fait toutes sortes d'interventions, ce qui, bien sûr, elles n'acceptent pas et la raison pour laquelle elles accouchent à domicile. Merci beaucoup. J'espère n'avoir pas été trop longue et avoir éveillé votre intérêt et vos questions. Merci.
Merci beaucoup, Dr. Florence Louis Vorbe, directrice exécutive de la Pro-Famille. C'est beaucoup. I would say in English for our English group also that, I like to say data, we need research and data, but the numbers equal an individual life, right? An individual who is struggling or choosing to be a parent, frankly, right? For those that are choosing to become a parent and to have to go through all of this is extremely difficult. But one of the things that, as Flora said, privilege, I have the privilege of sitting in New York and working in Brooklyn, New York, in fact, that has some of the not so great maternal health indicators in the country, in the United States of America. And so because the work that I do in my other work, as well as my work that I've done in Haiti, as well as being privy to some of the policy work that we have done and advocated for in New York, bringing on Dr. Pardo was really important because of the great work and research and impact that she has had in working with Haitian women in the US. I'm going to say in the, I guess, tri-state area, but certainly in Brooklyn. And I always say to people, women are the same everywhere. It's a little bit different, but many of the challenges outside of the basic medical needs, which obviously are extremely important. At one point we talked about in New York about respectable birth. And the Department of Health did a whole policy of what does it mean, respectable birth, and the importance of midwives and doulas and so forth. And so I'm really happy to have Dr. Pardo with us today to share with us on the other side of the waters, as Florence mentioned, of maternal health for Haitian women in the US. And then if you have questions, please put them in the QA. And I'll pass it to Dr. Christina Pardo. Thank you.
Thank you, and thank you for the invitation to participate in this. Thank you to Dr. Florence for her great presentation. I'm not sure everybody would understand me if I did all of this in French, so I'm gonna do it in English. And obviously I do understand, so certainly once we get to the question and answer, I am able to understand if there's a question in French, but I will most likely respond in English. Do you guys see the right screen?
We do. Haitian Maternal Health.
Yes,
Right.
you're not seeing presenter mode.
I see the Haitian health status in the US. No, I think you're good.
Oh yeah, no, I think
I
it's,
see where it says next slide.
yeah,
Yes. So you want to
let
put
me
it in
switch.
slides.
Okay. Okay, so I'm gonna start a little bit just at the high level to summarize, just to even the plane, depending on how much or little people do work in the field of health disparities. So in general, in the United States, we have racial and ethnic health disparities. That means that Black, communities of color, Black community of colors, different communities that are disenfranchised have poor health outcomes. And health disparities, we know, are considered preventable differences in health outcomes between populations. And, it's much like it is in Haiti, a kind of a complex determinants that are contributing to what's happening there. It's, not much different here, where there's a mixture of racism and discrimination, and there's also a mixture of what's available to us in our communities, barriers to care, like, as people will say, like the social determinants of health that are contributing to that. And then all of that is always just more complicated for those that have recently arrived here in the United States. And there are additional barriers related to being foreign born or immigrant status. So if we take a deeper dive at maternal health disparities, so Black women have increased risk of poor maternal health outcomes. And once we start to try to take a deeper dive, so I will say, and I don't know if I included that in here, but in general, it's harder, or there isn't that much data or information available for subgroups that may contribute to what overall, Black race or any ethnicity. So it is so those who consider themselves Black as a race are all lumped into that when they look at health disparities or for outcomes. But depending on where you are, if you have a larger population of a certain group, you'll start to see some more studies that will take a deeper dive on particular subgroups, which is important because all different groups have different characteristics and contributing factors, and even ways that we intervene and support different groups. And so when we look at the Haitian population, not a surprise, the areas where you will see some studies are in Boston, in Florida. I included New York in there, but we're really lagging. It's, we don't have as much as Florida and Boston does as it relates to maternal health disparities. At least that's at least through what's published. And Canada actually has a lot that supports this in general, that compared to US born Blacks, we see that where studies have been done in these populations, Haitians have increased risk of maternal health, different perinatal health outcomes like preterm birth, low birth weight, C-section, preeclampsia, and severe maternal morbidity. So wherever we looked, we see that there is something going on there. And as I mentioned, unfortunately, New York is really kind of behind Boston and Florida and Canada in having published studies around this. The underlying causes are not well established, but are a combination of many things: the socio-demographic factors, uncontrolled pre-existing medical conditions, and we know there's a lot of layers to that. And now You know, what we're seeing recently with the most recent migratory patterns, you know, you see a lot of differences and even compared to like 10 years ago. Recently arrived migrants have significant exposure to stress and trauma, which will likely impact pregnancy outcomes. And we saw a little bit of this when we kind of talked to our group. I'll speak a little bit more about that. So just to kind of paint the picture in general, just from the health aspect to what contributes to maternal mortality, important to say that actually the majority happens after the actual birth. So maternal mortality can be, and the traditional is up to 48 days. And then now we usually use this term like pregnancy associated, which means going up to 1 year. So most of the deaths are actually happening after delivery, and the most being in that like first 7 days. And the leading causes have maternal health conditions have become number one actually in New York, not for Black women though, but it is number one. Bleeding, cardiac, heart condition. So the more traditional biomedical things are going to be similar to what we see in Haiti. So bleeding, heart conditions, infections, blood clot that can occur in the lung, and preeclampsia or hypertensive disorders of pregnancy. So to start to look at New York City and what kind of led me down the path of some of the work that I've done. So as I mentioned, we don't have much published for New York City, but the New York City Department of Health did publish a report several years ago now on severe maternal morbidity. And when they looked at it, they actually also, they looked at it at many layers, one of them being the nativity, the country of birth. And so what they found was that, you know, a woman born in Haiti actually had the highest risk of severe maternal morbidity than any other group in New York City. And as you see here, kind of in this graphic, it shows a difference between the white, Black, and those born in Haiti. Babies born to Haitian immigrants have had higher rates of infant mortality compared to the New York City average. And in their, you know, kind of focus groups and different assessments, they found that Haitian immigrant mothers reported more experiences of racial bias compared to, you know, other communities born, you know, outside of the United States. And to kind of bring you home to kind of, you know, our view when we kind of started to wanting to take a deeper dive on this, and we looked at like the maternal morbidity in New York. I'm showing like a map here of Brooklyn. I'm not sure if you guys can see my pointer, and I highlighted 2 circles on this map that show 2 different communities in New York City, one of them being Borough Park and one of them being East Flatbush. And so for anybody that has, if you have familiarity with New York City, or East Flatbush is home to the largest population center in New York City. That's where Little Haiti is located, in that Flatbush, East Flatbush area. And that is also the community area that has the highest risk of that same poor maternal health outcome. And so that's when we kind of started to take a deeper look to see, you know, how we can support our community. I'm an OBGYN here, and I recognize that New York City was doing a lot of great work and around maternal health disparities. And I felt that more intentional was needed as it relates to the Haitian population, because as we know, and even some of the barriers that was just in the previous presentation, around cultural and around also being a new person in this, you know, country and different language, that, you know, there's something more that needed to be done. And so, we really felt like we needed to document what was happening and what the needs were. Because, unfortunately, in this, health world, if we don't document it, it will be hard to kind of push things forward. So we developed kind of this program to be able to do those things. And I want to acknowledge the initial partners in this program, SUNY Downstate, where I was when I started this, and the community partner, which we started this work with, Life of Hope, which is a community-based organization in Brooklyn. And so, as I mentioned, my formatting got messed up. I apologize. We really felt it was important to document the needs and document the experiences. So not only so we can kind of develop interventions, but really make sure we highlight the need. And so the map on the left just shows where all of and now I think the program has been ongoing for 4 years. And so the map on the left just maps where the participants of this program are, where they reside or where they're coming from. So you see most of them, the highest concentration in central Brooklyn. But what we're really surprised to see is that there's a presence all over New York City. And we felt that, people from the Bronx or in Queens were being referred to us, or, self-referring. And I think part of the reason is because we were providing a support and a service that was unique and very much tailored to this population. And so, we found a lot of, people would reach out to us even outside of our specific catchment. I have my community health worker had funny story where she called somebody to do an intake, and then the person was like, wait, I have 2 other people here for you, so there was like a lot of kind of that we saw, and most of the zip codes, as I mentioned, are in that central Brooklyn area, and just showing a little bit of the background around the self-report education status, with 73% reporting high school level education. Not surprisingly, the household size can the average being between 4 and 6, and increasing from that point, with a lot of many families residing in the same locations. And we started to look at the pregnancy risk factors. And now, since it's been several years, we wanted to see what the trends were, across the years. And then so we saw that cesarean delivery were the highest self-reported pregnancy risk factor. Again, and this is important because C-section is a significant contributing factor to poor health outcomes, like hemorrhage and infection. The other things that we saw that were more prominent are hypertension. Going towards 2024, you start to see gestational diabetes begin to increase. And there were some things that weren't present, previously, that started to kind of show again in 2024, where, people reported low birth weight. I will say that, people are enrolled, can be during pregnancy or postpartum time period. So sometimes we have people who enroll after they've delivered. And so, in assessing the social barriers of care, for every year that we assess for this, over 20% reported, transportation or childcare as a barrier. You do start to see like a decrease in that 23, 24. This is all observational, so we cannot make any conclusions, but I will say there definitely was a lot of different shifts in these last 2 years, especially with the with the parole program and changes, and like those that were coming to the United States and enrolling. So I wonder if that had a contributing factor, or what people felt comfortable sharing. Again, we're not able to make conclusions. We saw this kind of across the board for all the years, where it's still quite significant when you compare to in general when you assess for housing instability or food insecurity, but there was a decrease throughout the year. So the housing instability, 2021, which I think was one of the more, before this time period, a more recent kind of spike in the Haitians coming into the United States, their most recent migration patterns, and it decreasing to where in last year 37% reporting housing instability, and similar for the food insecurity, where in general each year we start to see a little bit of a decrease. Transportation and childcare, where for both over 20% are reporting that this is contributory factor. And again, each year we're starting to see it decrease somewhat. This particular information was really quite shocking to me. And when I saw the decreases in everything else, and so maybe wonder if it's something about the way that perhaps we're assessing or asking or what's going on. But in the opposite, we see that for domestic violence, we see a significant spike in 2023 and 2024 and reporting some level of physical harm. And when I spoke to some of the people, a lot of people kind of did mention experiencing that when they're speaking to clients, of having, kind of concerns around domestic violence. And I've participated in other presentations where, there definitely has been an increase in gender-based violence. And again, this kind of difficult migratory pattern, and whether that's what's contributing to this. And we also did kind of an assessment, a survey of childbirth experiences as well, again, to try to really understand, not just numbers, but, in people's voices, what is going on. And so we did a survey that was based on Mothers on Respect Index, and overall respondents scored having a high respect during prenatal care and childbirth. However, we started to see kind of some discrepancy and concerns when it related to autonomy and decision-making. And so these are kind of some of the quotations that people left. I won't read through some of them, but again, some people, like for example, in the middle, so I didn't feel discriminated against, I felt well received. And then others reported kind of their experience with at different levels, the front desk, the practitioner. Even one person kind of talked about a comment made by a doula and something related to immigration status, so that says that kind of levels of discrimination really are wide-ranging. This is just a summary. So as I said, overall, 87% reported, high respect. What was some things that were interesting? We asked about doula access, and only 44% reported knowing what, a doula was, again, which is something that's been a big part of intervention here in New York City. I think I have a lot of thoughts about the way doula support is, and it probably is not the best for all, thinking about some cultural, aspects, but definitely there's a lot of work and awareness and education around that. 13% of clients did not feel comfortable disagreeing with care options. 80% felt pushed into accepting recommendations. So that's where we kind of see that discrepancy around autonomy. Majority said they had access to translation services, and about 50% received some level of support. And then so if we kind of look at the levels of kind of the barriers that contribute to, at least in this case, the Haitian population, but we could say the same for many kind of immigrant population, but there are certainly quite differences for the Haitian population. You know, we have, you know, the racial aspect that's quite prominent, unfortunately, here. And then we add the level of immigration, the distrust with the type of care, fear of immigration status, unfamiliarity and language. And then we kind of add, you know, the level of, you know, being Haitian, where, you know, Haitian Creole being quite, you know, a distinct language where there isn't always a linguistic equivalence is really an important part. There's a lot of specific stigma and bias as it relates to the Haitian community. You know, unfortunately, that really just is still present now, and some of the cultural aspects that was mentioned in the prior presentation. And so that's kind of where we have from that taken where we have what we think are current recommendations, what we currently work to build on, having a culturally tailored health information, increased access of Haitian health care professionals, doing a lot of capacity building with healthcare institutions around providing care to the Haitian community. Information, you know, unfortunately, as much information that we can get and share will really help to move things forward. When we kind of show the information from Department of Health, that really helped us to move forward doing some of this work. And, you know, we really prioritize engaging community members because they know best the way to engage or the way to help support their healthcare, you know, access than myself or even those who have been here for a long time. You know, we really see differences in those who have arrived in New York and within the past 10 years. So engaging current community members in this has been very helpful. And just want to thank everybody that, you know, has been a part of this ongoing program. Oops. Stop share.
Wow. Thank you so much, Dr. Christina Pardo. You know, I said women are women everywhere and deal with different things in different ways. And thinking about New York City around issues of housing access, in Haiti, women obviously have issues around housing access as well, and or having practitioners who speak the language, the culture in New York is certainly a need, but also the correlation around just the economics of things for all women. And perhaps in the US, they have access to WIC and Medicare, or Medicaid, excuse me, which is helpful, but it's not the guarantee, right, that they're going to come in and continue to have access to services or come in for those services. And on the other side, in Haiti, it's, you know, as Florence mentioned and made a good point around what it costs a woman to go and access medical care, from having to bring in her own gloves or pay for those types of things, which is ludicrous to me in 2025. But it is what it is. And so there are so many barriers, but I do appreciate that each presenter also shared very concrete solutions. I'm going to now open up just look at the question and answers. There is a question here that says, how would you say or explain what a doula is? It's not quite a midwife or femme sage. So Florence, is that something that you all are trying to implement also in Haiti, or is it still very much focused to femme sage? I know there's another more informal name that I can't remember at the top of my head, because femme sage midwife is would be a trained nurse in Haiti. But the doula, how do you, or are you all kind kind of exploring that in Haiti?
Not yet really, because we have, of course, the midwife that are registered personnel, as you just said, health professionals, and we have the traditional midwife that we call the matron here in Haiti. That are those women, while they exist in all cultures, I think, while the more modern don't have them anymore, don't have a need for them anymore. But those are women that learn the work generation after generation, and they are the one who attend the birth with the women. So those are the one. We don't I am a doula. I am a certified doula on my own because it's
Okay.
something that interests me.
Yes.
But doula work is not very well known here in Haiti yet. The private physicians don't work with doulas because, as I said, they are the one who do the accouchement. They have this
Okay.
mindset.
Okay.
So they don't accept it a lot, but I work on my own with women that call me to support them. But
Okay.
it's not yet something that is generalized here in Haiti. But once the family has its maternity, I always talk about it because it's
Sure.
it's one of our projects, and well, we have not been able to materialize yet, but the project has the doulas concept in it.
Okay. Thank you so much. And well, I know Dr. Pardo has to go, but she wants to answer this question before she logs off.
Yes, I apologize. I have my clinic right across the hall and they're calling me to assist with something. I just wanted to say that, usually our team will just, find all kind of ways to explain it. It's like they may say like it's like a, like the matron or whomever that provides the support during the pregnancy. I find that whomever that we usually explain it to, then they're, they're interested in it, or they say, they have their, prefer their family. And I do have to log off, but I would love to hear Dr. Florence, if you have a succinct way that you explain what a doula is when you're speaking to somebody. And I will throw out there, so if somebody has interested, one of the things I would love to do, I just haven't had the capacity or time to do it, knowing how the Haitian community is and how family, how important family members are, really wanted to find a way how perhaps you can do some kind of doula-like training for family members, where perhaps not to be a doula, but to provide the, doula type support to pregnant individuals. And so, I have that on like my list. I think that would be quite impactful for our community. And again, I apologize that I have to log off.
We'll talk again. Thank you so much, Dr. Pardo. Thank you. So I
I
do
will,
want, I
yeah, I
received,
will try to answer that a doula is just a support person that supports the choices, the informed choices of the women. While midwives, for example, is just the arm of the doctor. So
okay.
that's
Yes, I actually received that from someone who is a doula on here who said that, doulas are to midwives what nurses are to doctors. So that additional support is, there are ways to kind of share that with a woman who's making a decision to have a doula. I've Florence, in your presentation, I thought was great, and I've met many women who have birthed in Haiti as well, and one who was 17 years old when she had her son. And she said, she went to the hospital. She was in a lot of pain, obviously, right? She's 17. And the doctor tapped her on her leg near her bottom and basically said, why are you making all of this noise and fuss now? You know, your mother sent you to school, not to be having a child at 17. And there are many examples of this. We've heard it, it's been documented, research, people have spoken about it. And so, as I said before, you know, we're all similar in many ways. And, you know, the US issues around racism and stigma and you know, Dr. Pardo talked about even discrimination against Haitians. It's, you know, this idea we want to have respectable births. How do you as a physician, right, share that message with your own physicians in Pro Famille and other maybe colleagues that you may know about the importance of this idea of a respectable birth in dignity, like you said?
Yes, it is really a change of mindset. So it's not just a communication or an information that you give. It's really some in-depth work in order to reach this mindset, because in Haiti, the physician is trained to feel like, you know, there's even how do you say, the proverb that says, après bon Dieu, c'est docteur. So it's a very paternalistic system where the doctor has all the power, knows everything, does not share. And the patient, you see the name, the patient, passive, come and she's just an object that we intervene on. But on the best that we can, because we study, we know what is best for her. We know best, we know better, and we just tell her without discussion. That's the mindset of physicians here in Haiti. So I always begin by the fact that giving birth is not something that needs a doctor. And this is, well, even if you are in a coma and you're pregnant, you will give birth without medical assistance if you have no complication. I mean. So this is not a medical matter. We do need doctors when there's a complication. That's what makes that less women are dying in birth, because for the complications, we have the UIN, but 70 to 80% of women are supposed to give birth naturally. And then there's a lot of evidence that show that interventions put the women of risk to have a cesarean, for example. Versus if you don't intervene at all and you just observe. So I come for the physician with scientific evidence that are more and more available these days. And also their compassion and their empathy, picturing these women as their wives, their mothers, their sisters, their daughters. That's how we do it. But there's a lot of resistance.
I imagine. I've heard. So we are going to close out. So if folks have any questions that they want to put in the chat, but you know, there's a lot of conversation globally around the I guess stopping of USAID by the Trump administration. Has that had any impact on Pro Famille, Florence?
We're talking about the US administration's top orders and this.
Yes, that the USAID Agency for International Development, which is globally around the world, obviously also based in Haiti. I wanted to know, has there been any negative impact or positive impact, maybe, I don't know, of the recent stop order by the Trump administration?
Yeah. There's been an impact, but not a fatal impact, but certainly a negative impact. because USAID funds were planned for 40% of our annual budget, from direct or indirect, how do we say, investment.
Mhm.
And fortunately for us, we have received exemption of the stop work orders for some of our projects, and one has been closed. But the one that has been closed is of minor significance in terms of quantity of money that was. But even like this, we still don't see the cash. I mean, they say, yes, 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 you can continue, you're exempted of the stop work order, but they don't give the money. So there is a good part of our operations that have stopped.
Mhm.
We cannot advance more money. And
Mhm.
also in the global panorama, all the partners, they are retaining liquidity
Yes.
and cash. So
Mhm.
it's really, really difficult to have
Mhm.
work done, let's say.
Yes.
And
Yes. Sure.
to put in disponibility of staff for the persons to be met.
Mhm. Thank you so much, because we know that even internet access is not always easy, and your presence today, despite everything going on, for us as the Haitian Women's Collective, I always say that we do not provide service. It really is about advocacy, and really being able to reflect the work that people who are local to Haiti are able to do. But without question, whatever happens with the USAID moving forward, or other organizations doing work around sexual and reproductive health, for the Haitian Women's Collective, we would advocate for having multiple similar pro-family models, because I'm, of course, a supporter of pro-family, of having quality health centers for women to access sexual and reproductive health services throughout the country in different departments. Florence did mention that they closed one clinic. Well, we really need to see more of those health centers throughout the different areas of Haiti. We didn't talk about birthing centers, and you did bring that up. It would be great if USAID, or whoever decides to move forward, whatever is going to happen, that they would also have birthing centers throughout the country and continue to focus on midwifery. We know that UNFPA is another kind of UN entity that focuses on women's health and maternal health and addressing issues of gender-based violence. So having birthing centers certainly would be extremely important. We know that the government in Haiti is in flux now, but whatever the future may hold, we would hope that, I know in flux is a very carefully selected word. um, we would expect that they would make a commitment to this as well, right? In partnership with USAID, UNFPA, whoever the other entities are larger NGOs, to look at ensuring that at these health centers throughout the country, that family planning would be accessible, and that it is also an opportunity with a new administration that would come on to decriminalize access to abortion, and in fact, ensure that women who need and want to have a safe abortion, that they would have access to it in Haiti, and not have to die from abortions that have not gone well, if you will. And then Florence, you really brought up an issue that was really important, and that's the access to or having a quality system in terms of access to clean, tested blood, right, for blood transfusions, because you also mentioned that so many women hemorrhage. And I have that example in my family, a young woman, cousin, who hemorrhaged to death after after delivering in Jacmel, which is in the south, for those of you who are not familiar with Haiti, at least I would say, I don't know, 2 hours away from Port-au-Prince, and her family having to try to get to Port-au-Prince to try to get the blood to assist, and that obviously did not have a positive ending. And so doing that, I know that there's been a push around midwifery, this idea of doulas, or training or supporting local entities, including some of our partners around this, I think, is so important so that we can have better outcomes. And of course, educating young people around their sexual health, their bodies, what it means to be pregnant, what it means to access services, kind of using the culture, but also using it in a positive way in taking away some of the myths around correct information, if you will, and having correct information for young people. So I want to thank all of you for participating. Florence, I don't know if you have a final word that you would like to share. Before I do that, there's one more question. Have there been evidence of Haitian women who gave birth in the US recently who have been deported with their babies to Haiti? I don't have that answer. Florence doesn't, but I certainly would not put it past our current administration. Florence, I'll give you the final word to close us out. And again, thank you for your participation, everyone. Florence?
Well, thank you, Karine, and I want also to thank Christina, even if she's left
Of
the
course.
call, but I will tell her personally, I learned a lot in her presentation because I didn't have the full panorama of Asian women in New York. But what is important is we know the causes, and we really have to work together. All these organizations that are part of the Asian Women Collective, I know some of them. We just cannot stop working, even if in this context,
Right.
because there is more work to do, and that's what I would really say. We cannot stop working because the needs are there and they are intensifying. So thank you all. Thank you, Karine.
Thank you. Thanks,
And
everybody, for your participation. All right, everyone, we hope you have a great day. Thank you. It seems to me that we might have to have another part to this conversation. Certainly for us at the collective, it is about the advocacy of how do we get funds to local organizations, because Flawless can't leave. Her staff cannot leave. They can't just get up and leave the country, right? And leave their communities behind. And so I honor them and thank them. And we will certainly think about what's next in this perhaps series of conversation or what our actions can be. So thank you again. Have a great day. Thank you to the interpreters, Natalie, Ruth, our team members in Haiti, Aline as well, for their participation in our ongoing work. And I wish you all a really wonderful day, and Florence, stay safe, and the best to your team also. Have a good day, everybody. Take care.